Good afternoon. My name's Ed Howard. I'm with the Alliance for Health Reform. On behalf of Senator Rockefeller and Senator Blunt and our board of directors, I want to welcome you to this program today on so-called communication and resolution programs, CRPs. People are going to be using that. It's not quite an acronym, but that group of letters over the course of the next hour and 15 minutes or an hour and a half. And you gotta have that in your head. Now, some of the most heated discussions in Alliance briefing history have involved medical liability questions. And of course, the key question, how do you protect patients from adverse events while you help practitioners have some peace of mind while they deliver the highest quality care they can? Now, some states have responded trying a whole variety of responses to that question. And today, we're going to take a close look at one of those, that is encouraging the disclosure of what you can call unexpected outcomes to patients. There are some pilot programs along those lines that have been in place now for several years, and we're going to examine how those programs are structured, what results they've yielded, and what the potential is for these CRPs, these communication and resolution programs. We're pleased to have as a partner today Ascension Health, the nation's largest nonprofit health system, and not coincidentally, designer and operator of one of those pilot programs that we were talking about. And we're going to hear from Ascension's Ann Hendrick in just a moment. Couple of housekeeping chores. If you're in a Twitter mode, note that the hashtag patient safety, and if you need Wi-Fi, the instructions on how to do it. I don't know if we had an instruction on the table, but we have the credentials on the screen right now, and you can take a look. Feel free to tweet about the program and join in the conversation. There are some good pieces of information in the packet, including speaker biographies that are more extensive than I'm going to be able to give our panelists today. There's also a one-page materials list in your kits, and along with copies of the PowerPoint presentations. A lot more background available on our website, allhealth.org. One important resource I want to call to your attention, thanks to our colleagues at Health Affairs, we've included in your packets copies of a couple of really important articles on this topic from a recent Health Affairs issue. And a recent Health Affairs issue. We're very grateful for their help in getting those reprints for you. If you want this whole issue, which I would commend to you, you can get it at an attractive discount using the flyer that's in your packets as well. Actually, I would suggest that you subscribe to the journal if you don't already. It's really the single best source of a wide variety of health policy analysis, and you'll get your money's worth. There'll be a video recording of this briefing available in a couple of days, followed by a transcript a few days later, both on our website, allhealth.org. At the appropriate time, you can ask our panelists a question, either by filling out one of the green question cards in your packets, by coming to one of the microphones that you see on the floor here, or by tweeting the question. We're monitoring the Twitterverse, if you will, so you have no excuse for not getting into the conversation. And at the end of the briefing, we're going to ask you to fill out that blue evaluation form in your package so that we can make these programs even better in the future. And if you're on congressional staff, would be especially appreciative of your filling out that evaluation form. Actually, from the very beginning of the Alliance's existence, our founder, Senator Rockefeller, has had it clear in his mind and made it clear to the staff of the Alliance that our main purpose is to serve the information needs of the Hill staff. So tell us what you need and we'll try to deliver on it. I want to note the presence without putting him on any sort of spot to actively address you, the senator from Rhode Island, Senator Whitehouse, who is off to our left. He is one of the most thoughtful students of health policy in, I was going to say in government, but in America today, I would say. Always asks good questions, and if you find one that you want to add, we will recognize you immediately. So, enough housekeeping. Let us get to the program. We have a wonderful group of speakers whom I'm going to introduce en bloc to avoid interrupting the flow of the presentations. And we're going to start with Dr. William Sage. He's a member of the law faculty at the University of Texas at Austin, where he teaches several health law-related courses. He's working now on a study of our subject for today, as a matter of fact, patient safety and disclosure, and another project on consolidation in the healthcare industry. And he's Dr. Sage not just because of his JD degree, a lot of us have that, but he's got an MD degree as well, both of them from Stanford, and I'm glad you've made it from Stanford to Texas, from Maine to here, in order to be part of our program. Bill?
Do you want to do the other introductions?
Dr. Sage has pointed out that I didn't do what I was planning to do, which is to let you know who the other panelists following are. I'm nervous. What can I say? Dr. Raymond Cox, on my immediate left, is the Executive Director of the Volunteers in Medicine Clinic on Hilton Head Island. Formerly, he served as the Chief Medical Officer at Providence Hospital in Washington and as Chair of the OB/GYN Department at St. Agnes Hospital in Baltimore. He's spent most of his career caring for underserved populations with an emphasis on maternal and child health. At my far right is Ann Hendrick, the Senior Vice President, Chief Quality and Safety and Nursing Officer for Ascension Health. Ann serves as the Executive Director of Ascension's Patient Safety Organization, and she's a nationally respected scholar in areas including geriatrics, patient safety, and organizational change. At the other end of the panel is Jean Rexford. She's the Executive Director of the Connecticut Center for Patient Safety, where she's represented the patient voice since 2004. Her mission, that of the center as well, is to promote patient safety, including the quality of health care, and protect the rights of patients. And she's an active member in a number of national patient safety initiatives. And now, as I prematurely said before, we're pleased to turn to Dr. William Sage.
Thank you, Ed, and thank you all for being here today. So imagine that you go to a hospital to have surgery. You would expect your doctors to tell you all of the risks of the procedure that you're going to undergo and all of the alternatives, and to go through those very carefully with you so that you understand what might happen to you. And indeed, as a matter of ethics and law and business practice, that will generally happen. If you're told about what might happen to you, the risks of your medical care, wouldn't you also think you would be told about what did happen to you if something went wrong during the medical care? You'd be surprised to learn that there has not been nearly so much a consensus about that simple fact. Communication and resolution programs are a rather acronymed way, institutionalized way of filling that gap. I've been asked to give you a very brief overview, and that's really what I'm going to do, and I'm going to save most of my comments for the questions and discussion where I can really be responsive to your concerns. Communication and resolution programs have very simple goals. Tell patients what happened to them when it's something unexpected, try to make things better, and improve safety for the future. Because as you might imagine, if healthcare systems are not accustomed to telling patients what happened and why it happened, oftentimes they probably don't know themselves. And if they don't know themselves, how can they improve safety for the future? Communication and resolution programs have a long history. There's been some adverse attention drawn recently to the Veterans Health System, but it was the Lexington, Kentucky Veterans Hospital in 1987 that pioneered the very first communication and resolution program, though it did not talk about it in those terms. It described it as disclosure, apology, and then an opportunity for compensation. Various large organizations, the Institute of Medicine, the Joint Commission, NCQA, others in the 90s, and some very large healthcare delivery organizations instituted systems that were basically systems brought within healthcare organizations, not independent physician practices, but typically hospitals, typically associated with the provision of acute care, that if something went unexpectedly wrong, patients would be told, some explanation and investigation would be begun, and ultimately some effort to put things right with the patient would be made, as well as some feedback to improve safety for the future. Different models of this have emerged, but that's the core features. Why are we here? Well, I'm partly here to talk to you about what these are in the world of healthcare. I'm also here partly because you all here in Washington, D.C. and in state legislatures have opportunities to contribute to the good sides of this. And in fact, legal issues do intrude on communication and resolution programs with the expected regularity that you would think they do, given the long overhang of medical liability as a policy and a political concern. So although this is an ethical and a practical commitment to patients, to be honest, to try to put things right, to have it not happen again, there is fear of litigation, there are various barriers to the patient's participation, and then there are the understandable concerns of healthcare professionals, which tend to fit in a mixed way in two categories: those that really center on reputation, what's these providers' self-image and image in the world, and then what are the economic consequences of that reputation and of other forces to the providers. And law influences and often constrains many of these factors. I'm going to divide law very briefly for you into two categories, and this will almost partition along committee jurisdictions. There's the things that have to do with civil liability and tort reform and malpractice, and there's the things that have to do with healthcare and healthcare financing. And they're both really important. I'm going to talk more about the healthcare and healthcare financing things because they're probably things that you didn't come here expecting to hear. And subsequent speakers, I think, will focus more on some of the liability issues. In your readings is an article that we published as a group effort from the ARC project back in the January Health Affairs that describes these in much greater detail. In the liability world, we're talking about the things you tend to think of as tort reform and then some other things that have to do with civil litigation. So first question you probably have is, well, is tort reform good for communication and resolution programs or bad for communication and resolution programs? My personal answer, it doesn't matter a lot, but it's generally better for being open and transparent and kind of adopting a new ethical paradigm and business paradigm in healthcare if you have some incentive to change, but you're not too afraid to change. And so a moderate liability climate tends to work the best for communication and resolution programs, which exist and thrive in states ranging from those with very strict limits on tort damages to those with no limits at all. But I would say if there are challenges, the challenges are at both extremes. In Texas, where there's so little chance of malpractice litigation these days that only a very progressive institution will take on the challenges of building one of these programs, and maybe at the other extreme, a state like New York, where people are so afraid of litigation so often that they're afraid to change their existing practice because they don't know what will happen. But basically, my message is that this isn't a reform that is linked either pro or con to damage caps. But other things turn out to be pretty important. For example, have some breathing space, some cooling off period between when events happen and when lawsuits are filed. having the various providers who are involved in these roughly in the same page in terms of their legal and economic incentives. So when you have highly selective immunities that apply, say, to a hospital but not to a physician, or to a public provider but not to a private provider, it may be that it's harder to get them to work together, as indeed they do need to work together to have the communication and resolution program succeed, to be in an organized fashion, be honest, make things better, and make it better for future patients as well. A lot's often said about apology protection laws, that you can't use an apology in subsequent litigation. My experience, very few people actually want to use an apology in subsequent litigation, in healthcare at least. It just makes your physician seem caring and compassionate and concerned with your welfare, not typically, if you're in court, what the plaintiff's attorney is trying to demonstrate. But indeed, people who are worried about their statements being used against them, an apology protection law may actually turn out to be very useful. And something that you might not have thought of, even if you're doing this voluntarily in complete cooperation with the patient, our experience is that the patient still needs some sort of legal representation. And shifting the expectations and the framework of the plaintiff's bar to participating for compensation in these types of programs is, I think, a very important challenge. The pieces that you probably wouldn't think of are things that really aren't about litigation and are more about the business and payment environment of healthcare. And I'll just point out two of the three on these slides. One is the National Practitioner Data Bank and other ways in which over the years we have passed laws at both the federal and state level to require the reporting of payments made to patients in connection with possible negligence by physicians. These were enacted against a backdrop of traditional litigation and silence and a deny and defend approach on the defense side that is not what CRPs are. We're talking about being honest and open. And there is a significant need, in my opinion, to revisit some of the data bank practices and some of the state licensing authority and reporting practices here, because otherwise physicians are quite reluctant to participate because of the damage they perceive to their professional reputation and their professional livelihood. And then for those of you who might have kind of Medicare and Medicaid jurisdiction as part of your portfolios, one of the biggest practical changes in litigation surrounding medical error has been the aggressive ways in which over the past few years Medicare now asserts its right, its legal right, to place a lien on payments made to patients that reflect in some way money that Medicare has spent on the care that the patient needed following an error. So right now, if a settlement is reached with a patient, Medicare is entitled to get back from that settlement every last dollar that it contributed to the patient's subsequent medical care following the event. These practices certainly have legitimacy to them, but they are really not well aligned with the needs of a communication and resolution approach. They do not serve the provider incentives well, they do not serve the patient incentives well, and they really lead to very unnecessary delays. And something that I think strongly needs to be revisited is the way in which Medicare subrogation, recoupment, and lien assertion interacts with this much more cooperative and point-of-care approach to dealing with medical error. And then this last slide is kind of the summary slide, and I'm sure it's not quite legible, but in your take-home copy at least gives you not only the bullet point category, but my opinion of what's most important to know about. So is this a significant movement? Or yes, it is. I think the movement towards transparency and honesty associated with error is just as ethically significant as the movement associated with informed consent was 2 or 3 generations ago. This is a big deal. This is not a trick of the tort reform side, a trick of the trial bar, or something that is kind of a fallback because neither side gets what it thinks is really important. No, this is about better patient care, and I think professionally it is very significant to both physicians and patients, and as a matter of fact, new generations of physicians expect to do this. They expect to be supported in doing it, but this is something they think is important. It's worth understanding that this approach to safety improvement is a transparent approach. It is not a We'll only be honest about what's happened if we work to fix it just ourselves, in a back room and issue a quiet technical report. Many of us thought that had a role 20 years ago. I think we've all gotten very skeptical about that. Transparency is good. CRPs contribute to transparency. This is about hospitals and organized health systems, not so much about individual physicians, except insofar as they participate in the systems. Individual physicians tend to be very, very concerned about individual reputation. This becomes a very difficult thing to do just by yourself. It's a very good thing, in my view, to attach to an organized system of care in which the professionals are supported. And what are often called care for the caregiver programs after medical error have turned out to be one of the very, very successful aspects of the CRP approach. I'd also sort of urge you not to think that just because a hospital now has a whole bunch of errors it's disclosed, that that's a bad hospital. A hospital that has a CRP program in place that has a lot of errors disclosed is probably a really good hospital. Just because you see the errors doesn't make it a bad hospital. It was a bad hospital when no one saw the errors. How much law do we need? This is, at heart, a self-help initiative, but as we've said before, law has an important facilitative and non-obstructive role. And then I'll save any comments about politics and tort reform for discussion. What I would urge you to do is look at this material, whether it's from me or from other people, with the least jaundiced view that you can bring to it. Don't regard this as, something coming from the usual malpractice constituents. Certainly in my writings, you'll see things that seem to fit the tort reform page mixed with things that seem to fit the trial bar page. But that's because this really isn't a civil justice initiative. This is a patient care initiative. Thanks very much.
All right. Thank you, Bill. We'll turn now to Ann Hendrick from Ascension.
Thanks very much. I'm going to move us quickly from the policy perspective directly to the patient care level. It's my pleasure really to share with you the Ascension Health experience around research findings from a multi-site, very large study around this topic of disclosure. I want to quickly mention what Ascension Health looks like because I think it really denotes that if Ascension Health can do this, really any healthcare system can, given our diversity. We are a large system. We have over 1,900 care locations in some 23 states, all of which have different tort reform or not. And we chose to center this study in 5 of those states. We have more than 150,000 associates who work hard every day to make care as safe as possible to those we serve with healthcare that works, healthcare that's safe, healthcare that leaves no one behind. So again, the reason I mention the size and complexity of Ascension is I think that these study results demonstrate what is possible when a structured disclosure program is put in place at any healthcare system. We believe so much in this that we have put forward a challenge to the healthcare industry that this should be an accepted standard of care by 2018 for every healthcare system in the country. And we are moving aggressively toward that own goal at Ascension Health. Let me now share with you a little bit of background before I share study results with you. For the last many years, we have had a very focused effort in the area of obstetrics because it's a primary concern for us for patient safety for both mother and the infant. You may know that most of the time during the birth process, things go well, but when they don't go well and there's unexpected events, they can go badly very quickly. Our obstetricians and nurses have developed a program that we call HANDS. You see the logo in the upper right-hand quadrant of your slide. It stands for Handling All Neonatal Deliveries Safely. And what this means is that we realize, much like in the safety industry, without the characteristics of high reliability, which means that we must train our obstetricians and nurses to anticipate the worst event possible, be trained for that, and then respond as a cohesive team. And they have done exactly that. So they practice on high-fidelity mannequins that this young audience would relate to. These mannequins actually birth an infant, and they do things unexpectedly. So it's truly testing the behavior and the competency of the clinicians. We also have online modules that test the competency around fetal monitoring, which means monitoring the baby's heart rate during labor to predict the fact that the infant may have non-reassuring heart strips that could suggest that there is pending trouble ahead for the mother and the infant. They also have been through cause analysis training. So when that unexpected event occurs, our team has been trained to go in and look at what just happened here. What can we learn from it? How can we become a highly reliable organization in this high-risk area known as obstetrics? So when the Agency for Healthcare Research Quality announced this call for proposals, it was music to our ears, because here was our opportunity to put together this package of interventions known as HANDS and couple with it this issue of medical liability and start to solve to that in a cohesive approach and to build a formal research study around it. So the results that I'm about to share with you come from that study. There were over 20,000 mothers who enrolled themselves and their infants at one of the most precious times in life, which is impending birth. So think about what that means from a patient perspective. During labor and delivery, they were willing to say, yes, I want to be part of this study, looking at safety, looking at disclosure, because should something happen, this is what I want for myself. So very high levels of patient engagement. As I mentioned, the study sites, there were 5 of them. They included the states of Wisconsin, Michigan, Maryland, Florida, and Alabama, all very diverse, both employed, non-employed physicians in these sites that we did the study in. I want to quickly review with you at a high level the 5 hypotheses, and you can read more about these in the Health Affairs article that was just mentioned. Also, there's an infographic in your packet that has a lot more detailed information. But let me quickly review, most importantly, the results on the right-hand side of the page. Again, keep in mind, this is 20,000 mothers and infants. Even though birth trauma and unexpected events are rare events, they do happen, and all of those were tracked and measured in the 20,000 mothers. We predicted that there would be a decrease in shoulder dystocia births. Simply put, this is where the infant does not progress as we would expect through the birth canal. It can result in a lifelong consequence called a brachial plexus injury, a permanent, partial, or temporary paralysis of the arm. Dr. Cox will share more with you about that, but it's a devastating injury for a healthy newborn infant and the mother and family. During this program, we saw a 48% decrease in the severity of those births from a bundle that was put together by our obstetricians and nurses. Secondly, we said that there should be a change in the delays of treatment when there is impending trouble or a crisis team needs to assemble, that we should be able to do that very quickly and get the infant out very quickly, much like in the safety industry. And in 98% of these births, those infants were delivered in 3 minutes or less. Now, this may seem like an obvious statement, but let me share with you, in most delivery rooms, that time is never clocked. So these physicians and nurses actually started a stopwatch at the moment trouble was recognized, and the study tracked that intervention. That is being spread now to all of our delivery sites, and we deliver more than 80,000 babies a year. Look at the percent of compliance in that area alone. The third hypothesis is that we believe that there would be a reduction in the severity of claims and also in the settlement amounts if this worked, because we were doing everything we could to prevent the clinical complication. But in the event that unexpected event occurred, we would fully disclose, once the event was investigated by the team, what just happened here. We saw a 57% reduction in the rate of actual and potential liability claims. Those are human lives. Those are infants and mothers who are seeing less birth trauma events in what is really considered a rare event analysis. And then the last two, an increase in the reporting of serious safety events. This really speaks to the culture. All of us have worked in a culture where you did not feel comfortable stepping forward and disclosing something. This meant at these sites that nurses, unit secretaries, housekeepers, anyone felt comfortable bringing a safety issue forward. We saw another 48% increase there. Finally, we predicted that there would be an overall decrease if these interventions worked. We didn't know if it would work or not. And again, keep in mind, these are rare events, so when you use a rolling 12-month average, in other words, an event will not drop off for another 11 months. We continue to track that in rare event analysis. We saw an 18% decrease. So simple summary, this had very significant reductions in all of the areas that we wanted to test around safety, high reliability, and disclosure. Let me move now to how did the disclosure process work, because this is really the key takeaways. It is very doable, and again, we're encouraging and challenging healthcare systems in the country to adopt the same principles, and many already have. First of all, that immediate reporting. Time should not lapse because we will forget or envision things happen differently than they actually did at the point of care. So immediate reporting to get the highest accuracy possible, and we call these trigger events, things that should trigger an immediate investigation. That is the continuous cycle of learning. What just happened here? How can we prevent this from happening again? That expedited investigation to look at cause and also to evaluate, is there liability? Was the outcome that was unexpected preventable? That is the key headline for us. Then also all of these events are logged, not only for study purposes, but for ongoing data mining. We have a patient safety organization at Ascension. We track all of our events, we mine those, and through patient safety work product, we transparently report them and send out alerts to all of our clinical and administrative leaders, so that same event will not happen in the same way at another facility. That's what will make healthcare safer in this country. Finally, ongoing communication. I want to say something about disclosure. It is not disclosing an event once. It's never enough because that was unexpected. It is a conversation. We need time to think, reflect on what you just said to me. I will have questions after you leave the room. I will go through a grieving process potentially, and we need to allow that individual to have time and space to do that. So we teach our clinicians that this is something that you must give time and space to. We will all respond differently. Finally, the resolution through communication. If we determine through the investigation that the unexpected outcome was preventable, we want to resolve this issue as quickly as possible to regain the trust of the family, and also if settlement is warranted, that we are moving toward that. We do not want to see any infant or other situation where resources could have helped the family to intervene more quickly. Let me quickly show you, this is what our event response team looks like. It includes the obstetrician, almost always the obstetrician who delivered the infant, the nurse, the risk manager, the neonate provider, and then a coder. Let me talk quickly about that. The reason we want a coder involved is for accuracy, so that we can do ongoing research and data mining around the event. So in summary, this can be described as what we call CORE: communicate openly, resolve early, transparent disclosure of unexpected events. And we plan to implement and sustain a proven model for talking with patients. We are now spreading this research from the 5 demonstration sites to every one of our delivery sites, which is 64 in total. You can imagine that is quite an enormous undertaking, as well as beyond OB. This is not limited to just OB, so it is how we work here. We believe it will reduce the likelihood of contentious and expensive litigation by doing the right thing at the right time for the patient. Thank you.
All right. Thank you very much, Ann. And we turn now to Dr. Cox.
Good afternoon, and thank you for inviting me to come speak with you this afternoon. As you can tell from my bio, my day job is running a large free and charitable clinic in Hilton Head Island, South Carolina. but by training and by calling, I'm an obstetrician gynecologist. And I'm excited and pleased to be here to talk to you about the wonderful work that is being done not only by Ascension Health, but by many other systems across the country. This work that was done through our research project was largely engineered and directed by Ann Hendrick, Ziad Haidar, and all of the hospitals that, the 5 hospital sites that were involved in this project had a very particular role to play in making sure that this project had the wonderful outcomes that you saw today. What I'm going to try to do over the next couple of minutes is to personalize for you the information that you heard from both Bill and Ann. 25 years ago, I delivered a baby who would go on to have a permanent brachial plexus injury. It took me about 7 minutes to deliver this baby. I'm not quite sure how long it took because back in those days, we didn't time the delivery. We didn't keep track of the time involved. We didn't have a coordinated, structured team response. And of course, we didn't do simulations to practice being prepared for these high-risk, low-frequency events. And afterwards, we were advised that we should not talk to the patient and family because that would increase the likelihood of liability by speaking directly with the family after the delivery to discuss this adverse event. So I decided to break the rule after this delivery, and I met, first of all, with the parents and then with their family members. There were about 15 family members that we put together in a conference room to not only explain to them what happened at the time of delivery, but also to give them the opportunity to ask any questions they might have about how this delivery took place and why their child had this outcome. We formed a bond with that family, and over the next 4 or 5 years, they actually sent us pictures of this little girl. This is not the little girl, by the way, but I wanted to give you a picture of what brachial plexus palsy looked like in a child after delivery, because sometimes, and particularly as OBGYNs, we don't see this type of follow-up. What was very important and very touching to me was that the family stayed in touch with me to make sure that I knew what the outcome of that child was. And by the time that child went to school at age 5, this palsy, this injury, had resolved spontaneously. And the child went on to have a normal childhood. Well, let's fast forward to what we've done through this AHRQ study. The work that we've done and the physician response to that work has really been truly remarkable. We actually started this journey about 10 years ago, as Ann mentioned, through the HANDS program. And a lot of the work in getting the physicians to buy into the disclosure process was really set up by the work that we were already doing through simulation. So getting the physicians and the nursing staff involved in simulation was really one of the first hurdles that we had to overcome, because the nurses and the physicians would run the other way whenever we pulled out the simulation mannequin. But over time, they began to understand how important this was, and they also began to understand that as leadership for the hospital and for the system, that this was not something that was going away, that we were committed to reducing birth injury, and these were the programs that we were putting into place in order to make sure that we could reduce the birth injury. So once we got their buy-in, they were actually excited and involved and even made many suggestions about how we could improve this process, not only in terms of the simulation training, but as we then had to address disclosure, we ran into a different set of issues. It wasn't just that some of them had buy-in on this disclosure, and the ones who were easiest to get buy-in were those who were employed by the hospital. But we had many physicians who had their own commercial insurance, and those commercial insurance companies didn't want their physicians involved in a disclosure process because they felt that that would increase their liability. So we really went through, and this didn't just happen at St. Agnes, it happened at several other hospitals across our system, one in particular. So there was that issue to overcome. Many people felt very uncomfortable about apologizing for events that took place at the time of delivery. But one of the ways that we were able to get through that, and I'm going to give you some of the responses from St. Agnes, was actually by working with the OBERT team, with the OB event response team. The risk manager, the physician lead, the nurse lead, who had been trained in disclosure, all of the physicians, by the way, and all of the nurses had undergone disclosure training, but these were the leaders in terms of helping physicians, the physician who did the delivery, actually start the conversation with the family. Initially, they were uncomfortable with that. In a relatively short period of time, the physicians, 85% of the OBERT or disclosure responses were actually initiated by the physician over time, which is a very encouraging result. The feedback that we got, I'm going to give you an example of the feedback that we got from one family that was involved in this. This is a little difficult to talk about, but one of our patients, we had a maternal death of a patient who was actually a colleague of ours, and the concern that I had as the chairman of the department at the time was that 2 of my physicians and 3 or 4 of my nurses who were involved in caring for this patient essentially came to my office and said that they were resigning their practice. They didn't feel that they could practice OBGYN anymore. They didn't feel that they wanted to be in maternal child health nursing. It was through the work of the OB event response team and through supporting those doctors and nurses, as well as obviously supporting the family, that allowed us to get through this situation. It was extremely difficult because we had to sit down with the family and explain to them what happened. Now, in this case, this was not a preventable event. There was nothing that we could have done that would have unfortunately changed this very unfortunate and this very tragic outcome. But what it did do was to allow not only the family to heal, because the family was brought in on several occasions to communicate with them at every opportunity that we got new information, if there was anything that could have been done differently, what the results of the pathology tests were, et cetera. So that process that we developed not only helped in our relationship with the family, but it also helped to save the careers of 3 fine OBGYN physicians and 4 wonderful OBGYN maternal child health nurses. At the very least, that in itself was a save from this group. Because at the end of the day, what we want to do is to provide a situation where we have a baby who comes out perfectly healthy, ready to take over the world. Not yet. Sorry, Dexter. Who's ready to take over the world. Mother's sitting there reading about this little tyke. There are rockets going off and cherubs standing around and storks flying, and the nurse is standing there making sure the doctor's doing the right thing. Now, Dexter. But we want to make, whoops, what happened? Well, we want to make sure that we'll know that we've reached high reliability when this woman and her baby have the same outcome as this woman and her baby. Now, here's my ask. There are a couple of things, and Bill already mentioned some of them, that I want you all to focus on as part of the congressional staff. One is that we need to federalize apology laws in a way that makes it easier for physicians to feel that we are enclosing them in a just culture. We're trying very hard to get away from the blame and shame environment and create an environment where we can begin to look at these adverse events and learn from these adverse events. And the current environment does not allow us to do that. The other thing from a legislative perspective that would be very helpful is by ensuring that liability providers, malpractice insurance providers, understand the role that they have to play in making sure that by changing how they address these adverse events, makes it easier for physicians to participate without feeling like that would lead to loss of reputation and make it difficult, particularly for the few solo practitioners who are left in practice, to not feel that they are risking their practice by participating in these types of events. Thank you very much.
Terrific. Thanks very much, Dr. Cox. And we turn now to someone who directly represents a consumer interest, patient interest, and that's Jean Rexford.
I represent all of you as healthcare consumers, as for your mothers and your grandmothers and your children. It is a system that is currently not working for the individual patients. Congratulations to Ascension and to what you're doing, Dr. Cox. These are what I call islands of excellence, and if we could replicate these throughout the system, we would actually still have a lot of problems, and I'm gonna talk to you a little bit about them. The way it is currently set up is cruel, and I'm glad you talked about the providers. It's cruel to the providers, and it is definitely hard on patients. My original board was made up of one man was George Meter. His daughter, who was 4, had a tube put in her ear, and she died. No one acknowledged any wrongdoing. It went to trial, and at that time, 6 years later, everybody was still blaming everyone else. And George kept saying, "But my daughter's dead." Another board member, Gus, lost 2 legs. This is when I learned minor surgery only happens to other people. Lost 2 legs during minor surgery. The physician left Connecticut, went to another state. That, of course, was litigated. But no matter what the financial end to all these stories, Gus will never walk again. So we have a system that is not working for patients. We have a system that is not working for physicians. I recently was up in Massachusetts. They have 7 hospitals that are now doing the apology. And what struck me as they were talking about their first year experience doing this was the physicians who had participated were traumatized. They were living with, as your health group did, they were living with the consequences of an action that harmed people. So if it's hard on the physicians, we can imagine that it is hard on the patients and their families. There is so much that happens to patients that doesn't bump up into the category of errors. Errors happen one at a time. So it could be in Maine, in California, in Kalamazoo, but it's 3 jumbo jets of people every single day who die because of medical error. And yet, because it is not a single jet, we are not paying enough attention to the problem. So if Ascension Health is just, they've been great. And Susan Davis, who was at St. Vincent's Hospital in Connecticut, worked with the Hospital Association in my state, and everybody's doing this high reliability work, which is exciting because the engineers from nuclear and aviation industries are in there, and they're saying, this is the reality of the care you are providing. And people react the way we all would with, oh my heavens, if that's, I want to do it differently. So these safety huddles that they're doing are a wonderful way to change. But change is beyond the safety, or the needs to change is beyond the safety huddle. I was a panelist last year at the Board of Radiology Foundation, and for 2 days they worried about the overuse of CT scans, especially with children. This will create cancer. And so for 2 days they talked about it, and I, like today, was the last speaker, and I said, not once did any of you mention conflicts of interest. If we have a new machine, it will be used to pay for that new technology. So we have, and let's think about competition between hospitals. If somebody is doing a new kind of surgery, the robotic surgery was purchased by one hospital in Connecticut, then another one had to do it. And people were using this without enough training, and people were being harmed. So somehow, the capitalism within this system is not necessarily working for patients. So we have a medical device industry. 90% of the medical devices that are implanted in patients are not tested. So the hip that was causing so much trouble with the Dupuis, I think it was the metal on metal hip, we don't have a national registry that keeps track. So within a hospital system that was actually doing really well on safety, that patient could have left the hospital. Is the physician tracking that patient? When that goes wrong, to whom does that patient call? We have one of the second leading problems for errors is communication. And yet, if you have ever been ill or had your going out with your mother or your father from a hospital on the directions that the hospital provides as you're leaving, you know that the communication is not clear. There's so many things that could be done if we involve patients from the beginning. Patients are smart, we care. Right now, we trust a system that is not necessarily trustworthy.
Thanks very much, Jean. Thank you, Jean. We now get to interchange among the panelists. I would encourage that, and you get a chance to join the conversation with questions, which I remind you you can accomplish either by coming to one of the microphones, filling out a green question card, or tweeting at patient safety. And let me start off with just a clarification question for Anne. You referred in one of the parameters that you had in the chart to a reduction in actual and potential liability claims. And I wonder, how do you measure potential liability claims to be able to get to a single-digit percentage reduction?
Good question. So I mentioned there are some trigger events that were unexpected. These are the events that don't necessarily cause an unexpected outcome, but they were unexpected in the situation or the practice. So we also monitored those as well. This is often what's called a near miss in the safety industry. And we wanted to have twice as many near misses being reported as we did actual unexpected events. That really is one of the best measures of a safety environment.
Okay. I should point out that we started early compared to our usual time slot of 12:15 to 2 o'clock, and we're going to end the discussion no later than 1:30, so you better get your questions in now. Some folks submitted them in advance, and I'm going to start with a couple of those if I can. We heard the reference particularly from Dr. Cox about the importance of the role of insurance companies, and both he and Bill Sage talked about this. And the questioner wants to know whether disclosure and apology programs can be successful without protecting the apology from the threat of a lawsuit. That is, can doctor-patient communications be truly open when anything the physician says can be used against him or her in court? Either one of you?
So the question was about the need for apology protection. I would say that most of the programs that are already in operation and most of the physicians who are already doing this, whether they're in a state with an apology protection law or not, they've become pretty comfortable. But if you really want this disseminated widely, one is dealing with skepticism and occasional paranoia. And in that instance, this type of a legal change is one that I think has very little downside, but can be reassuring. One of the great challenges in many areas of health law and policy, of course, is that it's a professionally driven endeavor with great social and economic consequences. Professionals are people. People have perceptions. A lot of things depend, and a lot of dollars depend on their perceptions. So often in the world of medical liability, you're dealing with very strong perceptions. Some are empirically justified, many are not. But nonetheless, there are instances in which accommodating perception can have significant benefits for the public, and apology protection is probably one of those.
So let me just add to that a little bit. Is this working? Can you hear me? Oh, okay. All right, better? Okay. Let me just add something to that. One of the things, there were several studies done a few years ago in the UK, Australia, and in the United States, and it was interesting because they were all consistent, that showed about 12% of all preventable adverse events ended up as a claim. Now that 12% figure, so then the question becomes, well, why is it that only 1 out of 7 preventable adverse events ends up as a claim? The typical reason why people sued was to find out what really happened. They felt like they were not being told the truth, that things were not being disclosed to them. One of the reasons why, we're so interested in this issue of disclosure and transparency is because it helps to reestablish and maintain the physician-patient or the health system-patient relationship. So that's a very important part of why these disclosure and apology laws are so important. A lot of physicians, like the example that I gave you initially, take the risk, so to speak, of divulging what happened at the time of an event. But a lot of times that takes not only courage, but it also takes the support of the hospital leadership or the health system leadership. If the health system leadership is on board, then that makes it easier for the physician to feel safe in reporting these apologies and disclosures.
And sort of picking up on that, Ann, you talked about Ascension's geographical spread, 23 states. And Dr. Cox made the recommendation that we've got to get the insurance companies on board in this apology business. And I wonder what your experience is from state to state in that area.
It is variable with the medical malpractice insurance carriers. As was said earlier, we're being very transparent about this. Some of the insurers actually said to the obstetricians that they had insured for more than 20 years that if you disclose an event, a serious event, to the mother, we will not insure you anymore. Now, part of this is the learning and building the knowledge, and that's where the research comes in. And the more studies we get like this that demonstrate it does not increase liability, then we can get the insurance industry on board with us. In fact, we did in the short lifespan of just less than 3 years within the study. By the time we finished, we had moved to the insurers actually offering premium reductions for the physicians who went through the full training. So again, it demonstrates, it is about culture and perceptions, and we can change those with facts.
Jean?
What I've learned is that everybody at the end of the day thinks they've done a good job because at the end of the day we're all tired. And when it's efforts like Ascension that stop to look at data, then they can see, oh, we're not doing as well as we thought we're going to do. I think some of the things that are happening now around transparency can be transformative. Many states are setting up all payer claim databases that are going to be providing, with the Affordable Care Act, they're going to be providing data on care and quality and costs. So there is exciting change out there, but it's state by state, and it is not universally packed in.
I've got a question from one of the cards, actually, also directed to you, Ann, at least initially. They ask if Ascension is using simulation with the new IT system implementation, that since new system implementation is a high-risk time for clinicians and patients. And actually, there's another question came in advance asking all the panelists to address HIT safety and errors, given that there's been so much in the news lately about HIT safety and breaches and the potential for errors that could affect a whole lot of patients at the same time.
I love the question, and the short answer is yes, we are. One of the things that we're doing now is we're bringing human factor engineers in to work with us. What we don't realize is that a lot of the medical device products that have been built are not necessarily intuitive for the clinician, and they can contribute to medical error unintentionally. So before we buy any new piece of equipment now, we have not a few, but frankly, hundreds of clinicians who are, it's one of the principles of high reliability, deference to expertise. They are the experts. They are the ones that should be testing and determining whether or not this piece of equipment or the EHR is constructed in such a way that it represents my workflow. So yes, we are. We need to do more of it, though.
Bill?
I'll give a little plug for my home institution, UT Austin. We have a grant since expired from the Office of National Coordinator for HHS to set up university-based health IT training. And one of the things we did in connection with building that program was we created an EHR learning laboratory that now has a lot of unusual features, including having a mock simulated, I should say, health information exchange. So it goes outside of any one provider organization, and one of the new initiative areas for our program right now is patient safety. And it's interesting because it's both a process of testing the systems that are in place and the information they provide, but also being quite attentive to the information they don't provide. A lot of the things that are required to improve safety and improve quality are not found in any health information system at present.
It's a little mind-boggling to me that we don't have a single gauge. And we figured out with railroads in our country that, you know, for railroads to get everywhere, we had to have a single gauge. We have not done it with health and information technology, so the patient is many times at a loss. Yale now has a giant system buying up practices, but if a patient were at Danbury Hospital, that information is not transferable. And yet in a mobile society, we are always moving. We are in other states, we are in other places. Somehow we have to figure this out, and quickly.
Very good. Yes, would you identify yourself, please?
Yes, excuse me. My name is Lisa Summers. I'm the Director of Policy and Advocacy at the Centering Healthcare Institute. Excuse me. And I'm trained as a nurse midwife, and so I had to get up here and say thank you very much, because this is just incredibly important work. And as somebody who had an experience much like Ray's early in my career, I really want to thank you. And my question is about a topic that often comes up in health reform discussions and at these briefings, and that's the topic of overuse and overtreatment. And particularly in obstetrics, we think a lot about overuse of electronic fetal monitoring and overuse of cesarean section. And often there's a sense that what drives that is fear of liability. That's what's driving particularly the C-section rate. So I'm wondering if you can share anything about, through your work in this area, do you think it's having an impact on that question of overuse or overtreatment?
I will. Let me give a primary example, and again, thank you for the provocation behind that question. One of the things that we've focused on is early elective deliveries at Ascension Health, and Dr. Cox and others really led this pioneer work long before the rest of the nation was looking at it. You may not know this, but many, many mothers in this country are induced prior to the 39th week of pregnancy with no medical indication. So we're not talking about inductions that are required for a medical reason, but the mother is simply either tired of being pregnant, the mother-in-law's coming in, or convenience, frankly. So, and it's more complicated than that. I'm just using simple examples, but these inductions are costly. They often result in a cesarean section because the mother was not ready to give birth, even under the best circumstances. Right now, our rate for early elective deliveries prior to 39 week is less than 1% in those 80,000 births. Our obstetricians have not stopped there. Our committee just adopted now going to 40 weeks, 6 days, because it is not until the 41st week of pregnancy that the risk of stillborn or complications goes up. This is not hard in fact, because as Dr. Cox will tell you, this is medical intuition and science together, and only the physician and mother can determine, but we are using that as a system standard. So that's one example where overutilization of induction contributes to poor quality, safety issues, and needless cost in healthcare.
And Lisa, to follow up on that, we thought we were going to see a significant reduction in cesarean section rate when we implemented this early elective delivery bundle. We really haven't seen that yet. What we have seen is a significant reduction in admissions to the neonatal intensive care unit, particularly from babies who weigh over 5.5 pounds, which is a significant savings and obviously a significant reduction in risk to those infants. But we continue to search for ways to understand what makes up that cesarean section rate and how various opportunities for overuse can be ameliorated through standardization of care. One of the things that we're committed to doing as part of our high reliability journey is making sure that we are standardizing those events or those practices that can be standardized. That's something that we're very committed to.
So 45% of what we do every day is from habit, and I would have to say probably with healthcare, it's even higher. So what you'll see when there's transparency are their practices that's what they do, early deliveries and cesareans. So the data becomes critical for all of you as you try to change this. They don't know that they're outliers. I think on the overuse with CT scans, the whole Choosing Wisely program is going to be also transformative and exciting, because we keep treating illness, sickness, and not health, and it's way too expensive.
I asked the organizers to include two of my writings in your packets. One is the CRP and law health affairs article that we've talked about. The other is a book chapter about the relationship between liability and healthcare costs, things like overuse, and it's called Both Symptom and Disease, meaning that liability does have some effects on its own, but for the most part, it shows the inadequacies and perverse incentives in the healthcare system more generally. I think Ascension's very much to be commended for having policies in place to prohibit early elective induction. If you were to get honest responses from many providers about why they don't have such policies, you would hear things you really don't want to hear. You would hear from hospitals that they really don't want to take on their obstetricians, who, by the way, are not typically their employees, and they don't want to chase them to other hospitals by telling them what they may not do. And you'd hear even some hospitals that say that they can't afford to lose the revenue associated with having a child born with significant complications that needs NICU care. These are not things we want to hear, but they are out there. And I think the more general lesson, if you'll let me retreat into kind of the academic policy space that I inhabit, is that often what we're buying and selling in healthcare are not real products. And as a result, we don't pay for them or produce them in the way that just makes sense. What you want is a safe delivery, and everyone involved in that delivery should be on the same page and paid all together to create the product and warranty it against these types of complications, and we don't do that. We pay for process steps, we pay separately for each component, and we get what we pay for, and it's often overuse.
Can I just ask, Bill, in developing these bundles, these products, if you will, is that an alternative to kind of evidence-based standards that might stretch beyond a community, which is kind of the standard of care that's now being used in liability cases? Is there a way to take the work that we're hearing about here, generalize it, standardize it, as Dr. Cox talks about, so that there is less reluctance to do some of the things that we know could help improve both cost and quality.
Absolutely, and I won't take too much time to elaborate. That's a different talk, Ed. But if one is thinking just logically about what you want to buy something that makes sense to you to buy, a medical outcome, a period of treatment for something that you have chronically, having a baby and having it all turn out well. You want a warranty associated with that, and you want to be able to measure at the end of the day whether you got what you paid for or not. And our healthcare system's just not set up to do that. The more we can move in the direction of setting up our healthcare system to do that, it's not a matter of a new list of real products. It's not a matter of, cookbook medicine. It's saying that no, everybody who's providing these real products will figure out how to do it right. And Ascension, in many ways, is figuring out how to do it right.
I just wanted to add, one area where I think we are seeing rapid innovation is through the CMS Hospital Engagement Networks, which is 3,800 hospitals. If you've not had a chance to peruse the website there, we are a hospital engagement network, and the Choose Wisely program is spreading. So I think we are seeing early signs of what's possible with rapid spread over just a couple of years, and it is having dramatic effect on hospital-acquired conditions and also on this overutilization issue.
There's a question submitted in advance by one of the congressional staff folks. Takes kind of a different approach to some of the questions we've been talking about. It's noted in the initial briefing paper, the questioner writes, that a potential avenue of achieving the goal would be preliminary disclosure of potential risks and unanticipated outcomes of medical services in question, as well as a potential agreement between the patient and physician for monetary compensation in the event these outcomes come to fruition. Would you liken this approach to a prenuptial agreement within the medical field? And how would monetary compensation value be determined prior to the medical services being administered, given the wide range of potentially negative outcomes possible?
Want me to grapple with that one a little bit?
Why not?
I'll grapple with that one a little bit. Okay, so here you guys will get to realize that I'm kind of a liberal Democrat who loves markets. Go figure. Markets are actually really resilient. We've had a long tradition of law in this country, predominantly at the state level, that says that you're not supposed to be able to bargain with your doctor in advance for under what conditions he can hurt you and what you get if he does. Against that's been kind of a theoretical literature on why contracts make sense. But while all of this goes on, actually the real world has figured out some good things to do. So there's a big field now of medical tourism, about, where people go get complicated medical treatment abroad. Well, most of the places they go abroad don't have the American tradition of civil liability. And in fact, there are companies that will sell you a first-party policy of, in essence, medical liability insurance, and you'll buy that as a patient before you go abroad, and someone who sells you the package here may incorporate that. This is an interesting legal and regulatory problem, but in general, why not? It's showing a market emerging to do exactly these sorts of things. I'm not sure about the analogy to a prenup.
Okay. Question for Anne from one of the audience members. In the study, what percentage of those who participated in disclosure discussions continued on to lawsuits? And why, if studied, was an offer of compensation rejected?
Again, we can refer to the Health Affairs article. Something to say about the obstetrical claims is that it's often one of the longest lag times for claims or a trial or a settlement, because of the very issue that Dr. Cox spoke about, is that until the child misses the first developmental milestones and it's proven that that is not going to be reversible, you don't see these claims. So we have a whole actuarial analysis set up around these 20,000 mothers. We continue to monitor. In the infographic, you saw that the baseline period was in excess of 7 million. During the 3-year study period, it is less than 1 million. And to date, that rate of improvement continues because there's overall reduced events occurring, again, rare events, but serious, and also then therefore less claims are following, both because they're not occurring, but also because disclosure. So be watching for additional papers for us coming out. We will keep the data set open for another 3 years after this study has closed in 2013 to make sure we're capturing the final outcome based on age of the children that were birthed in that last year.
Go ahead.
When I was up in Massachusetts, they were, after a year's experience, they were thinking that it is critical for the patient to have access to a lawyer early on to help with the negotiation so that the patient and the family can feel well represented and not overwhelmed. When bad things happen, you're so right. It takes a long time for people to sort of adjust themselves to a world that is very different. And so it is not quick, it is complicated, and I think legal support on both sides is critical for a good outcome.
I just want to strongly agree with that. Most of the programs I'm aware of that operate these CRPs not only prefer that the patients be represented, but they go out of their way to help the patient find good, competent, non-conflicted representation. It's definitely a change in how the plaintiff's bar does business because it's not long delay, it's not high expense, it's not high risk that would justify a high contingent fee, it's compensation. It's a different type of law practice, but I think it's very fulfilling to the people who do it, and it's evolving slowly in the different states that have providers who are doing CRPs.
Great. Dr. Cox? You wanna
No,
answer that?
that Bill said.
Okay. As we go into the last few minutes of our program, I would ask you to pull out the blue evaluation forms and fill them out as we hear the last few questions, one of which will come from the gentleman at the microphone.
Thank you. Mike Stinson with PIAA, representing the medical liability insurance industry. And I just want to make one very brief point, because I don't think it's been represented here, is that medical liability insurers have actually been leading and innovating on some of these programs for many years. And in fact, PIAA sits on the executive committee of the Collaborative on Accountability After Medical Injury, which is aggressively advocating for these programs across the country. Kind of following up on the comment you just made, Dr. Sage, I wanted to get Ms. Hendricks' perception on whether or not the idea of bringing attorneys into these proceedings, whether or not you've experienced that, and whether or not that is helpful. It would seem to me that that would immediately change it from a cooperative procedure between the patient and the provider to one of more of an adversarial nature. And have you had any experience dealing with that in Ascension?
Just to be clear, I understand your question. If in fact the patient is represented, thank you, by counsel, is that your question?
Yes.
Yeah, always. And we have expertise here that can comment as well, but we encourage that. In fact, I can safely say we would not go to resolution without that representation.
I would just have to add here that, in my personal opinion, I think PIA and its member institutions have been leaders in collecting data that bears on patient safety and patient safety improvement over the years. I think they've been laggards in sharing that information.
Question about timing. How quickly after an event do you talk compensation with patient families? And I suspect that's both in practice, in actual experience, and in analytical terms when you're trying to devise these programs.
Let me make the first comment on that, and I know you want to, but from a physician perspective, there's a lot of difference between an apology and a full disclosure. And you heard Ann talk about the fact that a full disclosure includes not only initially meeting with the patient and their family to explain the events surrounding the adverse event, but then apologizing for whatever that adverse event was, and then stating to the family that that you will make a determination as to what caused that event, and then in a timely manner get back to the family or back to the patient and let them know what your findings were, and what, if anything, needs to be done to prevent this from happening again. When we talk about you know, federalizing laws for apology, we're actually talking about federalizing laws for full disclosure, because that's the safe environment that we want to create. That's the umbrella that we want to create to make sure that we're able to establish a just culture that will allow us to develop these relationships, redevelop these relationships with our patients that we used to have a long time ago, okay, before all of this complexity came into this. So essentially what we're actually talking about is creating that type of environment.
Bill?
Ann, did you want to add to that?
I would just add that it's difficult to give you an exact number because they're so highly variable depending on the complexity of the case. What I can say is that it's gone from years to a few months or weeks compared to how it used to work. Again, we want to be thoughtful about the investigation, giving the family and patient time to work through disclosure with the providers that they trust, and it is much shorter than it was previously.
And does the compensation discussion necessarily involve, I don't know, despite my JD, what the term is, but admission of guilt? In other words, if there is, we've heard over the years of programs that covered immediate medical bills and used that as a device to try to get to an early resolution to some of these claims.
So this is just a good clarification for the people in this room who actually have a longer history with this general area. One of the first well-known programs for immediate disclosure, apology, and compensation was through the Colorado Physician Insurance Company, or COPEC, and it was called their 3 Rs program. It was a very successful program, but it was not highly formalized in the sense that it wasn't legalistic. Patients didn't release their claims. There was never actually a demand made in writing, and the amounts that were paid to help the patient and the family with kind of their immediate financial needs, with freedom to sue afterwards. But it was typically administered for relatively low-dollar events. The communication resolution programs that we're talking about now and the ones that are growing up at the major institutions tend not to follow that model. Instead, they do require release of claims. They tend to be able to deal with higher dollar events. And for that reason, representation of patients by lawyers is extremely important, and everyone acknowledges that. So if you're thinking the 3 Rs program, great program, and there are other ways to do that in kind of a really non-adversarial context. But what we're talking about here tend to be the larger events, the higher dollars, and it does have to be somewhat more structured and legally formal.
Very good. Well, I think we have come to a good stopping place in this conversation. We haven't quite solved all of these problems, but we have some evidence of progress in a variety of places. And we have a topic that we're going to keep an eye on and try to come back to as those developments warrant. Thank you for your active participation in the program. Thanks to our colleagues at Ascension for both contributing Ann Hendricks' expertise and to co-sponsoring the event. And I would ask you to join me in thanking the panel for a really good exposition of some tough issues.